and HER2 negative, which means it lacks all of the targetable characteristic of breast cancer. So it is defined by what it isn't, and this is, of course, is not particularly helpful. So you saw this slide with Dr. Peter Schmidt. So there are, however, molecular entity within triple negative breast cancer that are worth knowing about, because they may be at some point therapeutically germane. So this is the CAGB 4063, which is a large neoadjuvant study entirely in triple negative breast cancer. And across the entire cohort participating in trials, there was a variety of subtyping effort done on all the triple negative tumor. Here you can see the different subtyping method which came up with some similarity and some differences. So using the modified PAM50 approach, most of these patients, approximately 90%, are basal-like. And using the Vanderbilt triple negative breast cancer, we can see a variety of different kinds of tumor within the triple negative breast cancer, which gets a little more consolidated in the MD Anderson Taiber on the far right with the luminal androgen receptor kind of driven group, mesenchymal group, and then basal-like group that both immune activated or immune suppressed. So what we understand that the triple negative is heterogeneous disease. And kindly note that these Taibers all have some elements of the tumor, as well as some elements of the local microenvironmental cells, and in particular the immune cells. So we usually treat our patient with triple negative breast cancer early stage by neoadjuvant chemotherapy, which actually provide prognostic information. And this was compared in this very large meta-analysis of over 11,000 patients treated in neoadjuvant clinical trials, demonstrating that in patients who had a BCR, event-free survival and overall survival was substantially better than those patients who had residual disease. And the next question is it prognostic? Yes, it is true that the BCR or residual disease is clearly prognostic. And we know that, as I mentioned from the previous slide, that the meta-analysis for an individual, the BCR is associated with much better outcome than having residual disease. So this is most notably in triple negative breast cancer, where those patients who have a pathological complete response have a hazard ratio of 0.24 compared to those patients who have residual disease in terms of event-free survival. So the next question, that is for an individual. So does a primary therapy or extra therapy that increase the rate of complete pathological response also lead to improvement outcome? And in fact, in this meta-analysis, we see quite the opposite. So there is no clear relationship between improvement in BCR and improvement in the long-term outcome. So in general, improvement in BCR has not reliably led to improvement in disease-free survival or overall survival in the early disease setting. So it's really important to remember that the improvement in BCR will only lead to better disease-free survival if the additional BCR occurs in patients who previously would have relapsed. So the data are very clear that the presence of residual disease after neoadjuvant therapy is associated with inferior outcome. Then the question becomes, can we improve upon this inferior outcome? And as Dr. Schmidt already mentioned, the CreateX, now we know that we can do that with the data from study like the CreateX trial, where a HER2 negative patient with residual disease showed actually substantial benefit when they received adjuvant capecitabine compared to no additional adjuvant treatment. So the absolute disease-free survival was very impressive, 14%, and the absolute overall survival was 8.5%. And this is actually driven by the triple negative breast cancer subset. So having residual disease does identify patients who benefit from escalation of therapy, and this has become the standard of care for triple negative breast cancer. But is the residual disease, is it truly predictive? And the answer is we really don't know. And I will show you as in this slide, as I discussed in the CreateX trial, the investigator just randomized those patients who had residual disease to capecitabine versus no additional treatment. And to determine whether residual disease specifically predicted benefit of a drug like capecitabine, for example, we would have to modify the trial design. Patient would still be randomized to capecitabine or no additional treatment if they had residual disease. But those patients who achieved also PCR after their neoadjuvant therapy would also be randomized. So we could determine whether it is just the residual disease patient who benefit from adjuvant capecitabine, or is it possible that patient who have a PCR also could obtain a relative benefit from capecitabine. So, so far we have been discussing the complete pathological response and the residual disease as a dichotomous endpoint. And now for individual prognostic information and for clinical trial analysis, it may help to have a more nuanced approach to residual disease. So residual cancer burden is probably the endpoint that has obtained the most traction so far. And as you can see, the RCB class is highly prognostic across all breast cancer subtype, and in particular, triple negative breast cancer. And what particularly is interesting is if you look at the RCB as a continuous variable, or what's so-called the RCB index, there is a linear relationship in triple negative breast cancer between the RCB index and event-free survival. So by having this more nuanced, continuous information, we may be able to provide a better information for our patient. And this is for the question if the residual disease can provide an insight into the mechanism of resistance to the therapy. And Peter already touched base on it. And actually, intuitively, this would make sense since one would expect that the residual cancer cells would be enriched for the resistant mechanism. And this is an example where changes in the mutation allelic frequency, which has been actually studied, where the investigator looked at patients who had received the neoadjuvant therapy for their triple negative breast cancer, and found that the mutation allelic frequency and gene copy number varied significantly between the residual cancer and the matched pre-treatment biopsy. And just for the sake of the time, I will review very quickly 3 clinical trials which tested capecitabine in the adjuvant setting post-residual. So the first clinical trial is the GCAM 200311, which is an open label randomized phase 3 trial that assessed adjuvant capecitabine after standard chemotherapy for patients with early triple negative breast cancer, and was presented at ASCO meeting, at the San Antonio breast cancer meeting in 2019 by the Spanish group. So this is the study design: patient with operable, node positive, node negative with a tumor 1 centimeter or greater, triple negative breast cancer with prior anthracycline and or taxane containing chemotherapy were randomized to either capecitabine or observation. Very importantly, the stratification factor included phenotype of basal versus non-basal according to cytokeratin 5, 6, and or epidermal growth factor receptor positivity by the immune histochemistry. The primary objective was to compare the disease-free survival between both arms, and they included also the overall survival endpoint. So when you look at the intent to treat population, the result did not demonstrate a statistically significant difference in disease-free survival between capecitabine and observation, and the same is true for overall survival. But very importantly, when the investigator looked at patients with non-basal phenotype, there was a statistically significant increase in disease-free survival and overall survival, as you can see on this slide. The result in the non-basal subgroup, which was approximately 25% in that in this study, suggests that the activity of capecitabine might be selective for this particular subset of patients. So this is the conclusion of the author in the prospective subset analysis. The TNBC patient with non-basal-like phenotype had a statistically significant increase in disease-free survival and overall survival with extended adjuvant capecitabine. Another important trial is the metronomic capecitabine, which was presented at ASCO 2019 by the Chinese breast cancer group. And this is the trial design, stage 1B to stage 3C TNBC, who completed the standard treatment, including surgery, neoadjuvant or adjuvant chemotherapy, radiation, were randomized to receive either capecitabine maintenance treatment for 1 year versus observation, and the primary endpoint was disease-free survival. And as you can see, the 5-year disease-free survival was significantly higher in the capecitabine arm compared to the observation arm, with a hazard ratio of 0.63. And they look also at the distant disease-free survival, which was also significantly improved with metronomic capecitabine. But this was not improved in terms of the overall survival. And the Chinese group, they concluded that the addition of metronomic capecitabine for 1 year significantly improved the disease-free survival in patients with early triple-negative breast cancer. Finally, over the next 2 minutes, I will conclude with this more recently clinical trials, which was presented 3 weeks ago by the ECOG Akron study by the Dr. Meyer. And actually, this is the design. So the E1131 was designed to test the hypothesis that patients who completed the neoadjuvant chemotherapy and have residual basal subtype triple-negative breast cancer at the time of definitive surgery will be expected to have the highest risk of recurrence and would benefit from adjuvant platinum chemotherapy versus capecitabine. So the eligible patient have to have a clinical stage 2 or 3 at diagnosis, receive taxane with or without anthracycline as a neoadjuvant therapy, and have at least one contiguous focus of residual disease that measure more than 1 centimeter in the breast, regardless of the nodal status. And at the trial screening, the tissue was submitted for the BAM50 analysis for TNBC subtype determination, whether it is basal versus non-basal. And patients were initially randomized to observation versus a platinum agent of choice, but very shortly after the trial activation and based on the CREATE-X trial, an amendment replaced the observation with capecitabine, which was given in this dose. So the stratification are listed below. And as you can see, the primary objective was to compare the invasive disease-free survival in patients with basal subtype TNBC and residual disease after neoadjuvant chemotherapy who were randomized to platinum agent or capecitabine post-operatively. And as you can see, 78% of the patients were found to have basal subtype, and the major of the event of the primary analysis were distant and local recurrence. And this is just to show you selected patient characteristics which were well balanced between the two treatment arms, and overall the trial included a fairly diverse patient population. 75% of the patients received prior radiation treatment to the treatment of investigation, and 85% of the patients received anthracycline and taxane at neoadjuvant therapy, and almost 2/3 of the patients had mastectomy as final surgery. And selected tumor characteristic, which also were well balanced. At the diagnosis, most of the tumor were high-grade clinical T2 and the clinical N0, N1, and at the surgery, most residual tumor were T1 and T2. And this is the result. So the 3-year invasive disease-free survival for patients with basal subtype residual TNBC was very low. So 42% in the platinum arm, 49% in the capecitabine arm, hazard ratio of 10.06. The 3-year invasive disease-free survival by the intrinsic subtype and the treatment, regardless of the treatment, patient had a poor prognosis overall, especially those with basal subtype tumor, and the rate of the recurrence was higher than previously observed in a trial like the CREATE-X. Patient with the non-basal subtype treated with capecitabine, the solid blue line in the figure on the right seem to do better, but the number are not robust. And with that, I will just conclude with the conclusion of the author. So for patients with residual TNBC after neoadjuvant chemotherapy, platinum agents are unlikely to be non-inferior or superior to capecitabine in improving invasive disease-free survival, regardless of the triple negative intrinsic subtype, and the event rate, which was much higher than expected, regardless of the treatment arm. Approximately 78% of the patient had basal subtype TNBC at the time of surgery, and the overall toxicity rate were similar in both arms, but a higher grade hematological toxicity were seen with the platinum agent, diarrhea, hand-foot syndrome with capecitabine, and also this result indicate that there is no role for adjuvant platinum after pre-operative taxane and anthracycline chemotherapy for patients with residual TNBC, and it also definitively reinforced the role of capecitabine in that setting. And with that, I would like to thank you all for your kind attention.
Well, thank you, Dr. Meteb, for this nice review about this topic. We'll leave the question till the end of the session, and the mic for you, Dr. Fahad, to introduce the next speaker.